especially about propagation of the one. Either it is propellant or the alveolus is propellant and there down also. This incisor position is not correct. They prevent the lower lip from closing. So they not only push the upper lip upward, they pinch on the lower lip also. So we have to push this incisor backwards and upwards. Almost like a floating teeth. Whenever you see this kind of floating teeth, that means the bone is very poor in that area. So you can see some teeth might have fallen off like this, right? So it's a deep bite, canine to canine. So we have advanced mouthwash, right?
Yes.
And the antibiotic analysis is only for the surgery. 1 or 2 days also this better. This was mostly it would have fallen off because the patient came long time back, right? 6 to 8 months back. Some of the teeth patients were lost. Severe bone loss, and due to tooth region. As usual, the lingual loss is more. That's why I'm thinking also. Okay, we'll see the panel. The root is also resolved. So we cannot place implant in 6 region. Probably we have to use the 7. Mentally that is okay. 6 we have to check the canal. So we'll plan. We'll see the 6 first. Okay. As usual I expected it is worse only. This is the 5 area. So we'll go to between 4 and 5. 4 and 5 looks okay. Right? This is the excessive canal, right? So try tilting it anteriorly. Either you can tilt like this or place implant in 4. This 4, right? Yes. The bone is not very much favorable, right? So we have to do alveoloplasty here. And we have to drill from there to there. Vocally, the width of the mandible is very less. Crystally it is okay, but it's like a hourglass shape. Here it is constructed. So if you place implant in 4 region, the problem is we will be placing implant in 7, right? There will be a long inter-implant distance. So that is why we are better to tilt it easily. Start the drilling from 4 to 5 area. But since the bone width is very less, it is quite risky. We should not perforate and go lingually like this. Because anatomy is slightly different. Okay. So we will try in the later now. A little is good. Of course, a short implant and all of them in different place. Definitely not 4 mm implant, less than 4 because of the cholecystectomy thing. This is 3 to area, but there is a periapical radiolucence is there. So we don't know whether that is a periapical pathology or C.Murugavel dysplasia, because it looks like a mixture of radiopaque mass here, right? It's radiopaque here and it is radiopaque. So mixed lesion, mixed radiolucent lesion. It's better to use a basal design here. Okay, we will design. During intraoperatively we can design. And we are going to check this first premolar. Bone is okay, not very great or not very good. We can place. We will check the second premolar. So here the mental foramen is more distal compared to the right side. It is near the mesial root of. So we can start the implant from 5 and tilt it mesial. It is the ideal only. Okay. Actually, this is a situation for bar, for lower jaw also. And we will try to see the 4-7. Mesial root, the drawback is it is close to the infected site, right? That is the problem. So we should not use a compressive implant or surface implant because it is exposed to the lot of infection in the mesial aspect. So if you are placing implant in distal root, we can place a compressive, but here the anatomy is not very good. Only here it will engage the compressive implant. Here the socket is very much wide, the root is very wide. Okay, so we can try the interdental area. Interdental we can place, right? We can place a good implant. Yes. But still the risk of infection from anterior part is there. Because the moment you extract this tooth, this defect is in communication with this mesial aspect. So either a compressive implant in the interdental area or select the mesial aspect, place a basal design, BCS design, 3.6 into 40. Okay, the limbal cortical plate is excellent. You see, even though it is only 2 mm, 1600 HU value. The only thing is there is a long inter distance. Otherwise, you have to explain it to the patient and go for a bar. Okay. So if you go for a bar, you can start this from yes. So the implant will exit here, right? And we can give one tooth cantilever, right? Okay. 6 area. Here we can place a short implant, right? 3.75 into 8 we can definitely place. So it becomes all on 5 screw retained situation. Right? Here we are avoiding cantilever. The pterygoid is excellent, right? The axial view will give you a fair idea about pterygoid. Okay, it looks very worse, right? Especially the pterygoid also is not favorable, right? The sinus is expanded till the pterygoid. Is expanded till the first premolar and little bit of canine. This side is somewhat okay, right? This is the canine area. 6 not good, 7 not good. Behind it there is some bone is there. We will plant the pterygoids first. Yeah, it's worse as expected. Okay. Can you see the sinus is expanded very much distally and downwards. So we have to plan for a transinus. So whenever it becomes a transinus, it becomes a very challenging situation. Especially there is no crystal bone here, it's only 1 mm, right? Immediately will be entering the sinus. Definitely you have to use a basal design here. Otherwise, if you use a subsurface implant, the 90% of the implant will be in the sinus. Yeah, there is more chance for it to get infected. So we have to use there is a risk of oral communication also here, right? So there is only no 0.1 of bone here, but we need a pterygoid, right? We will see whether we can give some cantilever, can avoid pterygoid, or some place from short-term cantilever. No, this is 6 palatal root. It's not good, right? No, it's not good. 6. This is 6 mesolut area. This is also not good. So this is 5. 5 also not favorable, right? See, the sinus has reached the apex and crossed beyond the apex, right? It's very aggressive with the implantation. Where can we place the implant here? We'll go to the 4. So if you go to the 4 means you have to give 2 teeth cantilever, right? So somehow we have to place a pterygoid or go for a zygoma. Okay. So if we tilt it mesially here, we can place a 30 mm implant we can place, right, along the palatal aspect. Trying to do a buccal to palatal approach is not good because the bone here is very thin and fragile. We will see the canine now. It's very poor, right? See the canine apex here and here. Very worst situations. Patient had any history of ortho? No, don't know. Past ortho patients were very worse. The bone situation is very worse. This is next to the canal, right? Here also the bone is very poor. Maybe we can try the palatal approach technique. Short, small diameter one, 3.75. We can place it palatally. That is possible maybe. 3.75, 13 or 1.5. Okay. Just we are trying for lateral area. So this is one technique where we are placing one implant close to the premolar implant and we are placing a incisive canal implant. Okay. So in the incisive canal we can place a, here BCC is possible, right? Here the bone quality is also somewhat good, 1400 something, 3.6 into 14 or something place. Okay. So here, so this is a canal. Instead of drilling through the canal, we are avoiding canal and drilling in front of the canal, placing a basal design. So better to go for a simple MultiUnit here, right? Because you see the 2.122 area. It is also very worse. See the width. The width is the width is 4 mm or 3 mm. The height is 15 mm. Right? But the width is very less, not only in the crest, in the mid part also. That is the challenge for him. So we can, there is no other option, we have to go for a palatal approach, basal design. Because if you place a compressive, almost this much amount of implant will be exposed. 1400 the nasal floor. So better to use a implant basal. See, in the panoramic we thought it was a good bone, left side. Here also the basal, 1900. The nasal floor. Yes, it is okay. So 3.6 into 14 we can place. Okay. No, that's it. We can place implant here. See here the bone height is around 9 mm. Right? And place only 8 mm implant. Place a compressive, a basal near the first premolar area. Okay, this is the first premolar. So first premolar one implant, tooth area one implant, the midline one implant. This is 3 implants, 2 implants on this side. 1, 2, 3, 4, 5. Totally 6 implants so far now. 6 is hopeless. This is 7 also not okay. From the 6 we have to tilt it. So pterygoid is good here. We are saved on left side. Tilt from the 8 socket. And a good length we can use along the palatal root of 8. Tilt it distally and then medially. After selecting the palatal root, there is no need to tilt medially, just straight away you can read. Okay. You can see here the left side pterygoid. Medial tilt. Okay. So here the challenge will be, all implants will be challenge. The more challenge will be the right pterygoid, because you have to cross the sinus and catch only the pterygoid bone. There is no tuberosity bone, there is no crystal bone. This 1.5 is okay. All other implants. So what we'll do is we'll do all implant MultiUnit on this patient. We'll discuss with the patient also. So clear how many implants possible? 7, right? Okay. Otherwise we have to place 2 zygomas and anteriorly 2 implant is enough, 2 pterygoid is enough. 4 and 6 is zygoma and pterygoid. We will see.